on COVID-19 and the nursing profession. And we've had lovely sessions in this and a very good participation. And we expect that this webinar too will be just like how we had the previous ones. All our speakers and discussants are not we know them well. All of you, those who have attended the previous two, know our speakers very well, and we are hoping to have a very rich conversation today on if anything has changed in the nursing profession regarding the COVID-19 pandemic. And I will just hand it over to my co-moderator, Dr. Derek, to give you the house rules.
Yes, thank you, Dr. Mary. Like I said, wonderful to have you all back with us. And again, wishing that we could have been in happier times, but the challenge continues. Just to request everyone, you can put in your questions into the chat box, and we'll try and forward them to the panelists. And also, I've put a YouTube live link into the chat box, so you can forward that to your friends and colleagues as well, so that in case they have a problem logging in to the Zoom meeting, they can follow this discussion on YouTube. So with that, back to you, Professor Mary Matthew, to go ahead.
I will ask Dr. Russell to take over. Dr. Russell, would you like to introduce the speakers for
Yes, I'm going to do that. Just one moment, Derek. Can you send Miriam is having trouble? Dr. Miriam is having trouble getting in. Can you send her the?
Yeah, I'll send her a link on
WhatsApp.
Yeah.
All right. I'm now, as I said, we're going to have our first presentation is going to be by Professor Dr. Kristen Jones. As Kristen heads this program that we have put together with the nursing the webinar conference, and she has chaired this panel, the international panel, and they've done some wonderful work, come out with putting out this guidelines. So Kristen, of course, is the director for the Center for Healthcare Ethics. She's also the head of the first Canadian unit of the international program of UNESCO, but importantly, she's also in the Department of Education. She has an important role as a faculty member and also with the nursing program of the Department of Education. And she is at the Lakehead University in Thunder Bay in Ontario. Is that right? You're part of the state of Ontario in Canada. And I'm delighted to have Kristen present today. After that, we will have Dr. Miriam Wagaru, Caroline Wagaru from Kenya, but I will introduce her because she's having some difficulty to connecting. So I will do it after Kristen's presentation. We will introduce Miriam. So over to you, Kristen. And yes, thank you.
Thank you very much, Dr. Russell. It's a pleasure to be here. I'm just going to share my screen here. I have a short presentation for you, and very thankful for everyone who has joined us here today from all parts of the world. And we're very excited to share a white paper that we've just prepared, and this is the first time it's being presented. So very much looking forward to your feedback about this work. The title of the white paper, Nursing and Healthcare Ethics Related to the COVID-19 Pandemic, Policy Guideline Recommendations Based on UNESCO's Universal Declaration of Bioethics and Human Rights. And this has been put together by a group of colleagues that I'm honored and privileged to work with. We call ourselves the Global Nurse Leaders Panel. First and foremost, I do wish to acknowledge Dr. Russell, Dr. Mary, and Professor Derek for their leadership, bringing this group of nurse leaders together for 2 webinars in August, which really helped us to have these conversations, to collaborate. We were able to create a publication out of those 2 webinars, and now this white paper. I welcome and acknowledge all my colleagues that are able to be here today with us, but there were also a number of other folks who were part of the original webinar sessions. So we had people from not only Canada like myself, but also from Kenya, Oman, Australia, the UK, the US, Israel, India, Hong Kong, and also United Arab Emirates. So 14 people were brought together representing 10 different countries, which I think is an important accomplishment. We based our original conversations and our continuing work on UNESCO's Universal Declaration of Bioethics and Human Rights. So all of these principles being considered by healthcare providers in their work every day. But now with the COVID-19 pandemic, we're thinking about these principles in a different way. We're blurring boundaries and borders and really having a much more global perspective about our work together. And the webinars in August 2020 were very much based on Article 13, so opportunities for solidarity and cooperation. Also important in this group's work together, and certainly in the development of this white paper, we kept in mind as a foundation the ethical principles, things like non-maleficence, autonomy, justice, beneficence, truthfulness, and trust. We were certainly guided by the International Council of Nursing's Code of Ethics, which is currently in revision. We also included, as nurses from different countries, our own national codes of ethics. Again, we looked at other documents such as international calls to action documents, and of course, we did an academic literature review. The intended purpose of the white paper, really 2 parts. 1, to present a call to action, and 2, to propose international healthcare ethics policy guideline recommendations. Really in the context of nurses' experiences, clinical experiences, research, administrative, educational, all these types of experience within this COVID-19 pandemic that we've all experienced together. And we kind of unpacked some of those ideas within 4 articles within the declaration. And so I'll walk you through some of those now. The first one, Article 18, very much about decision-making and addressing bioethical issues. So what we recommend here for policy and practice changes and really perhaps enriching these opportunities is that there be a sustained effort for activities that support nurses to uphold their obligations, so their duties of care, not only as professionals, but also as individuals, and opportunities to support their personal moral values. Recognizing that healthcare providers are individuals, they are professionals, but they're also part of communities. And so the things that happen within their professional life also spill out into their personal and their community roles and responsibilities as well. Looking at opportunities for better collaboration with knowledge sharing, engaged dialogue, and encouraging that as key stakeholders, nurses really must be included at all levels of planning and protocol development, even in crisis situations. And the key point here is that nurses must not be excluded from ethical decision-making activities. Article 19, this one speaks really to the role of ethics committees and thinking about perhaps the role of ethics committees in your own organization during the COVID-19 pandemic and how often they were called on to make some of these key decisions. So this particular area of the document really looks at the opportunity for the voices of nurses to be heard on ethics committees in various healthcare settings to guide things like research, clinical decision-making, policy development, and ethics education and awareness. So even in crisis situations, the value of having a group of individuals, frontline people, senior leadership people, coming together to really make evidence-informed decisions about organizational policies and protocols. Article 20 about risk assessment and management. Perhaps before the pandemic, we might think about this more in the context of patients and families, but nurses' perspectives on this have brought up the issue of the need for risk assessment to also be considered in the context of healthcare providers. So the way that this area could perhaps be managed better and what we could learn from our experiences in the pandemic is how information is delivered, how it is received. We think about the timeliness of that information and opportunities to really have information and good communication contribute to health protection and promotion. Again, not just for patients and family members, that's really important, but also for frontline healthcare providers as well. So ongoing collaboration and coordination. We know we have multiple modalities for communication in this day and age. And so the opportunity to use those different modalities in a very strategic way to get people the information in a timely way. And here, frontline nurses and other healthcare workers must have their concerns about safety, protection, and adequate support addressed. And we've seen this throughout the pandemic with issues with access to PPE, varying protocols about which types of PPE should be used, a lot of different information being shared where healthcare providers perhaps are feeling unsafe and unsupported. The last article that we specifically brought into consideration is the opportunity for transnational practices.
Kristen, you're muted, Kristen.
Thank you. So the opportunity for transnational practices, and I think this goes back to what I was saying about blurring boundaries and borders. And it does go back to the original intent of the webinars in August. So opportunities for solidarity and collaboration. So in the context of the declaration, transnational practices really speaks to research endeavors and appropriate ethical and legal review. Also very important during the pandemic. But again, thinking outside of your organization, thinking outside of perhaps your country, where are there opportunities for reciprocity? We all need information about the COVID-19 pandemic. We want to share best practices across countries and across borders. We want to look at places that are doing a really good job so that countries who are struggling don't have to reinvent the wheel in terms of their practices and their protocols of how best to address some of these issues that we are all facing. And we suggest here that there's an opportunity for national nursing organizations to have an engaged role in supporting some of this decision-making and some of this knowledge transfer. And I think that such actions really recognize and value the importance of global efforts of nurses, really as a worldwide community. And I know for members of the Global Nurse Leaders Group, we've had an opportunity to experience the value and benefits of working as a worldwide community of practice and really thinking about the key issues that need to be addressed. So from this white paper that was just finalized in March, we are presenting a call to action really with 4 pillars. So the first pillar is to encourage what are ways that we can really protect and promote not only the physical, but also the mental health and well-being and safety of nurses, really all healthcare providers who are working in various healthcare areas and environments around the world. So not just acute care settings, but all sectors of healthcare. The second pillar to recognize nurses as key stakeholders, the largest group of healthcare providers worldwide. Nurses with the need for equal partnership. We have valuable insight, valuable perspective to provide, not only at local, but at national and global healthcare domains. The third pillar is really to support leadership opportunities, continuing ethics education, and training and development for nurses in different roles within organizations. We want nurses to be fully engaged and to have opportunities for meaningful consultation, both in direct and indirect ways, when we're making decisions about patient and family care, community and public health, and also policy and legislation development. So really asking for engagement at all levels. And pillar number 4, opportunities to increase the number of nurses in formally designated leadership positions. So not just having nurses being brought to the table, but also being in decision-making positions strategically. And we especially encourage this in roles that may have traditionally been held exclusively by medical doctors only. So with that, I thank you very much for listening to really a synopsis of our white paper, and I'm really welcoming the opportunity for us to discuss where we're at now within this global pandemic. So thank you very much.
Thank you, Kristen. That was timely and excellent. I thought it was wonderful overview, and we're going to expand on that in the next session that Mary will lead. Now I'm delighted from Canada. We are now going to move to East Africa in Kenya, and we have the secretary of this of our international panel, or the expert panel, Dr. Miriam Carol Wagaru. Is that, am I pronouncing you right, Miriam? You want to unmute yourself?
I'll talk to you in the morning.
Yes, thank you.
Okay, I just wanted to make sure that we're on. Dr. Miriam is the clinical mental health nurse and an international research ethics specialist, and importantly, she's also the director of the School of Nursing Sciences at the University of Nairobi in Kenya. And indeed, Miriam has played another active role with Kristen in bringing the white paper and bringing the guidelines together, including publishing first the proceedings of our 2 webinars. So today, Dr. Miriam Wagaru is going to talk to you, and she's going to present the nurses' response to COVID-19. Should the roles change for better population health outcomes? And indeed, it's very important. Whether we listen to you, Miriam, and let's understand the importance of whether we need to change to improve population health outcomes. Certainly, that is an important aspect of population health outcomes. So over to you, Miriam.
Okay, thank you so much. And I'll share my screen now.
Dr. Miriam, if you can increase the volume, the volume of your computer so that we can hear you better, louder.
Oh.
Yeah, now it's okay. Now it's okay. It's fine. It sounds.
Is that okay?
Yeah, it's okay.
All right.
Do you want to, I think, can she make the screen, Mary, does she make the PowerPoint bigger, or?
Yeah, just go for full screen. Yeah, perfect.
Yeah,
Good.
Is that okay now?
Yes, perfect.
So thank you so much, and good evening, good morning, or good afternoon, everyone. And I acknowledge the webinar lead and chair, Professor Ruzel, and the webinar co-chair and moderator, moderator of the chat system, and the chair of the Global Nurse Leaders, and all members of the Global Nurse Leaders panel. I appreciate uh, that we're able to join now, and I want to thank the organizers for giving me opportunity and having me in this webinar. Now, by way of introduction, we know that COVID-19 pandemic has created a crisis that has aggravated the risk of ethical problems among healthcare workers. This crisis is felt overwhelmingly among nurses who form greatest percentage of health workforce. We know that nurses provide up to 90% of healthcare services and stay with the patients for 24 hours, especially in the low and middle income countries in Africa. Now, in the midst of this fear and stigma associated with COVID-19, and when the majority of citizens are working from home, nurses have had to leave their comfort zones to fulfill their professional mandate, which can be summarized as to promote health, to prevent illness, to restore health, and to alleviate suffering. Now, when fulfilling the professional mandate, nurses' interventions comply with ethical principles, and these have been implied in Christine's presentation: the principle of justice, the principle of beneficence, the principle of non-maleficence, the principle of accountability, fidelity, autonomy, and veracity. So to answer the question, should nurses roles change for improved population health outcomes, I would like to base this argument on the quote by Charles Darwin. Charles Darwin in 1859 said that it is neither the strongest nor the most intelligent of the species that survives, but it is the most responsive one to change that will survive. So if we look at the pandemic, the COVID-19 pandemic, from a nursing perspective, I think that the pandemic has been a wake-up call for all of us in the healthcare to enable us change our ways of doing business, especially in the aspects that we have taken for granted for so long. I have a few examples to give because my presentation will be a very short one. I want to look at whether the nurses' roles should change for improved population health outcomes with regards to advocacy role of the nurse. We have always said that nurses have an advocacy role to ensure that interventions conform with ethical principles. If we look at the ethical principle of justice, for example, we are asking ourselves, how can nurses ensure that justice is provided and that we reduce the deepening health inequalities in healthcare for the marginalized? Many times when we talk about the marginalized, we think of people who are socioeconomically disadvantaged. We think of the adolescents, we think of the women. But there is a certain group of people that we think about, but we never think about how the nurses can communicate with them. For example, you want to talk about the dumb and the deaf. We always say that this is a specialized group. But then we ask ourselves, in our nursing education curriculum, do we have a way of teaching nurses, for example, the sign language that they can use to be able to communicate with people who are dumb or people who are deaf when they come to our healthcare facilities. In most of the curricula in Africa, we do not have specified areas to teach nurses how to communicate with the deaf and the dumb. This pandemic has taught us that we need to include these members as well, because if we do not, then they will fail also to seek healthcare services. And in that way, we are not going to provide care to them. Because when you talk about justice with regards to care, we are thinking of allocation of resources and equitable healthcare that meets the needs of every population that is supposed to come in to seek our services. We also talk about the expanded role of the nurse in management, and this Christine has also alluded to, that nurses provide 80 to 90% of healthcare services. Nurses stay with the patients for 24 hours a day. Yet when formulation of policies is done, nursing workforce is rarely included. And the question we are asking here, how can justice be done to those who are receiving care if the majority of the healthcare providers do not participate in formulating those policies? We also find that in terms of management, we rarely, like in African situation, we rarely get any CEO who is a nurse. And then it means that justice in healthcare is also interfered with, because if you have to go through a very long bureaucratic process, then it takes time to make decisions that can benefit the patients whom we want to provide care to. So advocacy role of the nurse needs to be emphasized in the nursing curriculum and policy documents. We talk about advocacy, but if you look at the nursing curriculum and you look at the nursing policies, we find that advocacy may be mentioned just once or twice. We are thinking that that should change so that it's emphasized. And if we do this, nursing advocacy role must also change from where we are now to better advocates for our patients. We also feel that we need to give more autonomy and knowledge to the nurse to act as patients' advocates, because we can only advocate for what we understand. And if we don't, we may not be able to be very good advocates for our patients. So then the advocacy role of the nurse as we know it now needs to be expanded so that the nurses can play a greater role in advocating for patients' care. And we know that this will improve patients' health outcomes. We want to talk about beneficence. We are asking what changes are needed for nurses to provide care that will benefit the clients. We need to expand the clinical practice rights of the nurse. We all know that globally, the patients who are receiving care at home are more than those who are in our ICUs, because our ICUs are limited. For the nurse to provide care that benefits the patient, then the nurse needs to know how to take care for the critically ill patients at home. This will require that we have some changes. We have changes that will provide for, especially I'm referring to in African situation and Kenya, where we do not have our home organized in a manner that it can provide critical care. So it means we must have the equipment at home. We must reorientate the nurses on their clinical practice. Many of our nurses must be taught on critical care nursing. Right now, we have very few nurses. And even when they are practicing at home, there are some procedures that the clinical nurse specialist in critical or emergency care should be able to perform. Many times, these are under the domain of the doctors, not because the nurses are not able to practice them, but because the role of clinical practice nurse is limited. So we are saying it is important that we expand the clinical practice rights of the nurse to be able to provide this kind of care at home. And this will benefit the majority of the patients who are on home-based care but need assisted care with the respiration. We also need to have laws that recognize the nurse's expertise. And this has been said by Christine. I may not make a lot of emphasis on it. And we also see nurses, we need to have nurses who are included in policy table for healthcare to discuss issues of quality and quantity of equipment, like the PPEs, the injections, and many others. Accountability, which is my last slide. The roles and responsibility need to be clear. If we want to be advocates and we want to provide care that is benefiting our patients, then we need to have roles and responsibilities that are clear, that we can know what we are accountable for. And this accountability need to be discussed and agreed upon at professional and multidisciplinary levels. This means that as a nursing profession, we need to identify the scope of practice for each professional at each level. And we need to communicate this to our members of the team in healthcare, so that they also know the scope of practice for the nurse, and so that the nurse can be able to be accountable for that. And accountability in this case will mean that even if it comes to legal issues, the nurse will be able to provide evidence and to provide the assessment that they have done, and be able to issue certificates in areas that concern their practice. Many times we know that when it comes to legality, the nurse rarely talks with authority and gives decisions on the patient issues. Yet, the nurses are able to do this. It requires teamwork, understanding of each other's role, which I have already said. And so I want to thank you very, very much. And that is the end of my presentation. Thank you so much. We welcome you now to ask issues on
Dr. Russell, you're muted.
Sorry, I don't know how this gets. Thank you, Dr. Miriam Wagru, for your excellent presentation on nurses' response to COVID-19. Should their roles change for a better population health outcomes? And we have both these presentations that have set the scene, and now we're going to move on to the second half, or the second part, not half, second part of this conference. And this is, of course, going to be moderated by Professor Mary Matthew. And I'm going to introduce, besides Professor Christian Jones from Canada, from Lakehead University, from Thunder Bay, and Dr. Miriam Carol Wagru from the University of Nairobi. We have now another addition of very distinguished nurses from around the world. Let me start with introducing Dr. Joy Kezia, who's the Chief of Nursing at the Apollo Specialty Hospitals in Chennai, in India. So we might get you to wave your hand so everyone knows who is Joy. And she was in the last webinars too. So very welcome to you, Joy. And I'm then have the great pleasure of introducing to you Dr. Joyce Newman. She's the program director in stem cell transplantation and cellular therapy at the University of Texas at the, I think it's the Anderson Cancer Center in the United States. I'm delighted to welcome you, Dr. Joyce Newman, for the second or third time. Welcome. And I'll now introduce Professor Dr. Selva Titus Chaco, who's the Dean and Professor of Nursing, the College of Nursing at the Gulf Medical University in Ajman. Dr. Selva, welcome, and it's a pleasure to have you here with us again. And then I'll I'm delighted to introduce to you Dr. Karen Castles, who is the Enhanced Psychogeriatric Resource Consultant, and of course at the Geriatric Outreach Team at the Woodstock Hospital, again in London, Ontario. And she's part of the team. We have Professor Shabir, who's also part of our team from her unit. So welcome, Karen, to the webinar conference today. We now also have, I'm delighted actually to introduce to you Kathleen Degani Condon, of course, from United States. She's a palliative care nurse practitioner at the Long Island in New York, United States. So we'll welcome you. And finally, of course, I'm delighted, Dr. Rhea Gal from Israel. She's a nurse and at the Soroka University Medical Center in Israel. So welcome to you. We have these distinguished 8 panel nurses from around the world, from different regions, who are going to now take us through this discussion conference. And I'm going to hand it over to the very able and distinguished Professor Mary Matthew, who will moderate this part of the conference.
Thank you, Dr. Russell. And before we start, I'd just like to congratulate Dr. Christian and Dr. Miriam and their team for putting out this white paper, which has brought out beautiful points for discussion today. And I think it shows the power that nurses have, in all situations, and particularly in pandemics. So congratulations to all of you who have contributed to that paper. And we are hoping we are going to have the next white paper following this this webinar regarding the second wave or third wave or whichever wave you want to call it. So congratulations. And what we're going to
I think we've
do is, and the second part we will talk. The second part we will talk about what has changed, or is there any, or do we need to review or relook at what we have put out during the first wave. So with that, I just want, before I ask our discussants their views on the white paper, Dr. Christian, just a comment or a thought from my side, and you can clarify because I'm not very familiar with the nursing, fraternity and the aspects of, the organizational aspects. But is it high time. Is it high time that we should have a global nurses crisis task force for pandemics? Do we have that in place, or are we going to think about it?
That's a very good question. So certainly we have the International Council of Nurses, and they've certainly put out calls to action in response to the global pandemic. But I think there's always room for more activity. And also, I think, we're starting to understand some of the challenges globally. Just in terms of different contexts in different countries. And so I think that's also one of the reasons why it's important to have general guidelines and recommendations, but also then those need to be adapted for particular contexts. And even if we just look at the nursing context, we know that nurses' roles and responsibilities, their ability to contribute on senior leadership or decision-making teams can be very different in different countries. So we certainly have our work cut out for us within this small team, as well as the good work being done by the International Council of Nurses.
Okay, so there is an existing task force on pandemics. Is my assumption right?
I don't know that it has that specific name, but they are certainly putting
for crisis and during crisis and pandemics.
Yes.
It is there. That's really good, because this is the best time to make to understand the roles and probably incorporate new thinkings and probably new actions to dealing with pandemics. Yes, Dr. Miriam. Dr. Miriam, are you there?
Yes, I'm here.
Okay. Okay, Dr. Miriam, you made a beautiful, I really liked your statements and your suggestions about teaching nurses, which I think is applicable even for medical, the medical fraternity, regarding teaching the sign language to our medical students and our nursing students. And that I think is very important, because those group of people are the ones who are actually neglected. And that is a brilliant suggestion. May I request everyone to mute their mics, please, other than the speaker? Yeah. So I think that is a very good suggestion. And another thing which I really liked was the advocacy part. We as health professionals, over and above our professional call as advocates for health, we should also, not only at the patient, the professional patient interface, we need advocacy also in the social realm, that is to the society, which you're talking about. But one thing, what is more important is also at the political level. Nurses have a voice, and they should also have this call for political advocacy, because they are the ones who can tell the governments what exactly is happening at the local levels. So it is not only professional advocacy, I'd say even social and political advocacy is very important. And this is I'm saying generally for all healthcare workers. And another aspect which we've never addressed actually, even in the medical curriculum, is management. And you spoke about CEOs. You don't see CEOs, nursing CEOs, at that level. It's always a doctor or something like that. But I think management also should be taught in a very, at least the basics of management to our nursing students, and also to our medical students, because we never know when they are called to take decisions and be in positions of power. So I think that is also important in the curriculum. Would you like to add on to that, Dr. Miriam?
Well, Mary, I can add a little bit here that in Australia, we have the Australasian College of Health Service Management, and nurses do have the fellowship, and they are actually part of it. And many of the nurses are CEOs or in many of the institutions or in organizations here.
Okay, but the problem is you have to take it as a special degree. What I'm saying is at
No.
the curricular level,
Yes.
at the curricular level, it should be introduced to the nursing students and to the medical students. That is my
That's a very good thing. That is part of management,
yes.
Bringing in, because in the past, I mean, you are managers, and ultimately, I think that's a very good, and I think that's something we've been thinking about in whether we should have in our courses itself something to do with management and probably human capital management. That's a very important part, managing human capital, which is not human resource. I'm talking of human capital
people.
management. Yes, people.
Yes.
Managing the capital. Yeah.
Yes. Dr. Maria?
Thank you, Prof. Matthew, for that, and thank you, Prof. Russell, for adding in. Before I talk about the questions you asked me, I think I may want to talk about the question that you asked earlier about whether there's a task force dealing with the issues that you asked. I think we have the International Council of Nurses, and Christine has said that very well. What I think needs to be added is the ethical aspect, and I think it would be good if the UNESCO felt that that piece of ethics is so that we have a specific in ICN dealing with ethical issues. I think that would be useful. Now, coming back to the advocacy, yes, I really agree with you. The political level is very important because politics determine a lot of policies and distribution of resources. Yes. And I think it is high time we can also teach our nurses to get into politics, yes, so that they can be able to influence policies from yes, there that will benefit the patients. Yeah, the issue of the issue of management in the nursing curriculum. Many schools of nursing in Africa teach about nursing management, and it is not just about all management, it's about nursing management. And so it means that when the nurse qualifies, they are better placed to manage the issues, the nursing issues, for example, nursing services. But I think what you are saying is very important, so that we teach the multidisciplinary approach to healthcare systems, and the nurse can be able. Now, the other issue that discourages the nurses is that even if they have learned that in their own levels, like at postgraduate level, they can qualify with their other counterparts from the same class, but very rarely will they be given an opportunity to practice the management that they learned as a CEO of a multidisciplinary institution. And I think some of this need to change, because it is justice in management, and when justice in management is lacking, then the consumers of the care may also suffer from injustices. Thank you.
Thank you, Dr. Miriam. We'll now go on to our discussions. I'll ask Dr. Selva to come in, and we are going to discuss about the white paper and if there is anything to be added, or has it changed now? So Dr. Selva, I understand that you have to, Dr. Selva, yeah. Are you there? Yeah.
Yeah, I'm here. I'm here.
Okay. Yeah, all right. Okay.
Actually, you know, this paper was done about almost a year before, and there's quite a lot of changes that has gone in based on geographical needs of each of the countries that are there. And so I would actually commend Kristen and you know, putting it through very beautifully. And I think quite a few of the things that are put on the paper has been at least initiated in most of the countries. So if you look at, you know, I'm trying to localize it to UAE, what's happening. in terms of decision making, when it was spoken about, I can see that being a small country, the whole decision making of how this pandemic patients, the COVID-19 patients have to be cared for, the nurse had a huge input, right? The nursing directorate had a huge input. So much so, what they did was they kind of, allocated which are the hospitals going to look after COVID patients and which are the ones that are not going to look after COVID patients. So that decision, major decision, was from the nursing directorate, because they need to deploy nurses in different areas so that care can be given for COVID as well as non-COVID. So what I'm trying to say is that it's a fantastic work. Initially, it was a lot of chaos because someone who does not have a knowledge about critical care is being deployed to work in a place where you need to look after. So quite a few of the things have been put into practice in terms of deploying nurses, and that major decision was made by the nursing directorate, because the manpower, when you look at, of course, medical person has to be there, but the larger number of population anywhere is the nurse. And so the deploying the nurse to learn to look after pandemic and curtailing it to a particular zonal area, the decision was fully involved with nurses. So I can just go on everything, intense training and making them. And then the other thing is, giving provisions for the nurse. And it's just not that you are only looking after unwell people, but also you have to care for the healthcare workers. Every bit of, ensuring that they have enough PPE, they have been given separate place to stay, they have been vaccinated. If ever found to be COVID, they have been on leave, to quarantine. So all those provisions that is needed to look after healthcare worker was also done in that sense of this thing. Other thing I also want to say is a beautiful thing I want to say. Actually, Dr. Miriam also brought in, there need to be reformation in education. That was what was brought. And it's amazing to see in UAE, after about after 2013, the Ministry of Health and Ministry of Education came together and brought in a proposal of nursing education reformation, because of the pandemic, to see how we address the education in such a way that they are able to prepare to come to a level of handling anything. So, we've been, as a dean, all the deans and all the Ministry of Health workers, leaders in healthcare, they both have come bilaterally sitting together, which has not happened. And now we have made a competency framework, which is now being benchmarked internationally and given for experts to come through, which is another excellent initiative that happened in terms of this pandemic, bringing in together and reformation. So I am not saying that most of the things that we thought of in our paper is coming into reality in different parts of the world. So that's something that I want to add on to. Yeah.
Thank you very much. It's really lovely to see the change.
Yes.
And that is what is important. Otherwise, the efforts go waste.
Yes.
Yes. Thank you, Dr. Selva.
You're welcome. Yeah.
Dr. Joyce? Dr. Joyce from USA, are you there?
Yeah, Joyce Newman.
Yeah, is she there? Dr. Joyce, are you there?
Yeah,
Hi.
yeah.
Yes. Hi. Okay. Hello.
Yeah, there you are.
Yeah.
Your views on the white paper. Do you think we need to now move forward and add on? Because Dr. Selva says, okay, whatever we had put in the first round we are seeing it come to fruition. Do we need to add on, or do we need to think about other aspects now?
I think that Kristen and the group did a wonderful job on the white paper, and it's very profound in terms of what they've put together and collaborated, integrated on. I think it's time to, look to what else can be done. I know the biggest issue right now is vaccinations.
Okay.
And how we can get healthcare providers the vaccinations they need, as well as getting our patients vaccinated. And there's a lot of differences I'm hearing about across the world, whereas in the US, with our new administration, which has also been a positive aspect that we've seen in terms of dealing with the issue of COVID, with our new administration since last August when we met before. We had an election, and things have changed in some respects, and the challenges that we were seeing then, I think, are being addressed very well right now. But we know that in certain countries, I was reading, I have companions in Japan and in that part of the world, and vaccinations and things are very limited, and only 3%, 2% of the population has been vaccinated. So healthcare providers were the first on the line to get for the vaccination, but I think getting it out to population. And that's one way that we can emphasize that with our populations in terms of the vaccination. There's some vaccination hesitancy that we can also, educate and be, I think, leaders on helping patients understand that. Nursing still is the most trusted profession, and the mistrust sometimes that goes along with receiving vaccination and also the control measures, not big crowds and all the rest. I think we can certainly help educate the public and with our professional organizations, but also through this endeavor.
All right. Thank you very much, Dr. Joyce. Dr. Karen, in Canada, we'll talk about the white paper. Would you recommend anything new, or have you seen changes?
One of the key themes that comes out of this discussion and the paper discussion, and thank you so much to Kristen and Miriam for the introductory pieces of that and leading into this, resilience really comes to mind for me. It's the resilience of the nurse, it's the resilience of the patient or the recipient of healthcare, and it's the resilience of the system. It will be some of those changes that come about from these powerful discussions at the table, empowering nurses to remain resilient and have that advocacy ability moving forward. I think the mental health focus on everyone as individuals, whether it's a recipient of healthcare, nursing, or organizations, and just everyone in general in society, we're not alone in this pandemic, and emerging through will really have a focus of resilience based on all the principles that have been discussed.
Yeah, thank you very much. Can I go to Dr. Joy? Joy Casey. Joy, are you there?
Yeah.
Joy, your views on the white paper and contributions?
Right, ma'am. A few thoughts that I've actually gathered from the entire webinar: how leaders can actually act as agents of change. We've been talking about nurses being empowered. We've been talking about ethical principles for nurses. We've been talking about patient rights and responsibilities, and there is so much to do actually. But we as leaders right here, many of us listening to this, and many of our thoughts actually going around our nurses and our patients, we need to realize that today's leadership is about being loud or bossy on the floor. It's more about, the mission here is that we need to demand for this compassion from the consumers of healthcare, our support systems within our own hospitals. We need the support coming to us automatically. We do not want to empower nurses to escalate mistakes and then ask for corrections. We need the other people. All of us realize that nurses are the largest workforce. So if a housekeeping person has delayed services to my patient, or if the food and beverages have come in delayed for my patient, or if there's a technical glitch inside my patient's room, the nurse has to act on it. And then we sometimes call this as nursing empowerment, which I strongly feel is not. We need to empower all these people who are supposed to be our support co-workers. They need to treat the nurses as their consumers, keep the nurses happy. And that's a long way to keep them healthy in the system. These nurses will not want to leave us if they are just happy. Just keeping them very happy every day goes a long way. That's my first point. The second one is, as a leader, yes, today we talk more of servant leadership versus a blaming leadership. So when I'm a servant leader, I work with my team. It's like a small child who learns her first few steps of walking. So she needs to be allowed to walk at 12 months or 13 months. So her first few steps are going to be feeble. She's going to slip and fall. So that is why me as a parent, I'm there with her. So what do? I guide her, I help her, I support her. So that is the type of leadership that we need to really bring in through these ethical principles. So we have ethical leaders who will be very strong role models who can actually practice the 4 C's. I've come up with 4 C's that can actually help a lot of leaders here. We practice coalition leadership. We coalesce with each other. I take your thoughts, you take my thoughts. We want to we want to come together and practice that. Then we practice consolidation. So even if the smallest member in the team comes up with a new idea, make it big, make her feel wanted, make her feel really advertised about for the solution that she's brought to the floor. Third C, practice cooperation. It's very hard to match the age groups that we're actually handling. We have the newest, the smallest, youngest nurse in her 20s, and we have the oldest nurses at 45, 50 plus. So we get them to cooperate. They need us to be there all the time. And the last C, practice composure. It's during the pandemic that you actually get to know how composed we are. It's easy to burst, it's easy to come out with different reactions. This isn't available, that is not there. It's easy to become very grumpy, but then it takes a good, solid, sorted leader to actually practice composed steps. So before I just finish, I came up with something. I was just reading something, and this came up really nice. Do not be daunted by the enormity of the world's grief. Do justly now, love mercy now, walk humbly now. You are not obliged to complete all the work that's before you, neither are you free to abandon the work. So, it's a very fine line between what we want to choose to do with the group of nurses that we are entrusted with. So these are the few thoughts that I have, Mary, ma'am.
Thank you very much. Very beautifully put. And I can see the leadership, the leader quality in you, Dr. Joy. Thank you very much. Kathleen, Dr. Kathleen? Kathleen, you're there?
Yeah.
You can unmute yourself. Just one moment. I'll send you a request. Okay.
Okay. Can you hear me now?
Yeah.
So it was been a privilege to work with this group of nursing leaders over the last year. And I was struck by some of the themes that have been discussed. Here in the United States, there is a program called Magnet where we identify healthcare institutions that provide exemplary nursing care. And research has really supported that excellent nursing care really makes a difference in terms of mortality and overall health outcomes. I think, in the United States, where there is a fair amount of care that is provided by physicians and other providers, it's very easy to lose focus of the work that nurses do. But one of those pillars is structural empowerment. And so institutions really have to demonstrate the ways that they have structurally empowered nurses. So I really think that what has been learned during COVID here in the United States, there are plenty of opportunities to create structures where nurses can use their expertise. And I think nurses, at least here, need to move away from language of I feel this or I feel that. Nurses have a real cadre of information that's not merely feeling, but is real expertise. And I think giving credit to that and naming it as our expertise is tremendously important for us to do. And then, you know, also to pick up on the issues of mental health. I think nurses have experienced tremendous burden. I've been involved within my own institution on preparing for a major national survey. And the work requires me to sit down with several nurses once a week to go through a survey. And the trauma that nurses continue to experience. Here, I live right outside of Manhattan, about 40 minutes away. So we were really one of the epicenters here in the United States when we had very, very little information to work with. And yet, as our state right now has about just over 30% of our citizens are members of our state vaccinated. We still see tremendous loss associated with COVID, and, you know, nurses that are on the brink of tears. One neighboring institution, a major player here on Long Island, and with a couple of institutions in Manhattan and in Westchester, so in the regional area, has actually developed a Center for Traumatic Stress Resilience and Recovery, primarily intended for healthcare workers. And really, healthcare workers, I think, you know, as nurses, we certainly care for patients, but I think this crisis has also certainly shone a light on the tremendous work that that other people that I think can be written off as, you know, mere supporters, the environmental workers, the dietary workers, also need a voice. And so I think as you know, we are being asked to verbalize our concerns. We have an obligation to also sort of bring some of those who are disenfranchised into the conversation, our disenfranchised colleagues, so that their voice is heard and that their needs are met. Because I think certainly if nurses feel like their needs are overlooked, you know, particularly nurses who are providing direct care, then certainly our other colleagues with whom we could not do our work as institutions also need to be heard.
Yeah, thank you very much. So true. I mean, but this is the result, the one of the good outcomes of this pandemic.
Agreed.
Yeah,
agreed.
Right. Thank you very much. Can we go to Raya? Raya's from Israel. Raya, you're there?
Yeah, can you hear me?
Yeah. Raya, your thoughts on the white paper and suggestions. Yeah.
Yeah, first of all, thank you to Christine and Miriam and all the team that put together this wonderful white paper. I actually want to emphasize the nursing force in Israel. I think that, as you know, a few months ago, our situation was one of the worst in the world. In terms of the percentages of the patients, the numbers of the patients that we had every day, also the severe patients in the hospitals. And then as soon as the FDA approved the vaccine, we were maybe the first or the second country to receive the
vaccine.
To our country. And actually, by building a very build and develop a strategy that all the population will be vaccinated in a very short time. We got to the point that 3 months after the 3 months since we got the vaccine, more than 50% of the population already got it. And actually we're back to normal life. We, since about 3 weeks ago, all businesses are open, everybody are back to school. We have a very, very low number of COVID patients. Most of the units and departments already closed. We have a very low number of severe patients still in the hospitals, but the majority of the departments, the COVID departments, are already closed. Performance are back. We are back to normal life. Tourism is back, and still everything is open. Starting next week, the government decided to allow people in an open space to take the mask off. So we are in a very, very good place right now. I must say that the success of the vaccination project was led by the nurses across the country. The nurses in the communities mainly, but also in the hospitals. They built at that time, they built a strategy that was able to use the electronic health record and a telemedicine to recruit and bring the people to the clinics. Okay. One of the great ideas that we had is that, you send an invitation to your clients to come to the clinic to get the vaccine. Let's say if you have a certain amount of vaccine, you send an invitation. Unfortunately, sometimes not all the people are coming at that time. And there was a big concern if we're gonna lose all the vaccine. So the nurses actually in that case, when they saw there is a leftover, they used the social media. And what they did in a lifetime, they send messages in every social media that exists. WhatsApp, messengers, Facebook, Twitters, TV, personal, whatever exists. In 1 hour, many people came and all the vaccine was used. So actually there wasn't any vaccine that we got rid. And I'm not talking about the cost behind that, but definitely about people's health and life. So that was a huge success. And I can just say that I can give the credit to the nurses. Majority in the community, but also hospitals took a also major role place in this project. And we are very optimistic right now, and I hope it would continue.
Okay, thank you very much. That's really, what you're saying is the power of the nursing force and the power of advocacy and the use of telemedicine and the use of social media. These are tools that we can use to combat this crisis, and very beautifully used in Israel. Thank you very much, Raya. All right. So we'll just move on to the second part of it. Dr. Kristen had to leave because she had another appointment. But what I'd like to discuss now is there is a saying which which I read. It says, "Never let a good crisis go waste." All right. So never let a good crisis go waste. Now in India, we are seeing, we don't know if this is a second wave or third wave, but we are in a crisis. Have we learned from our mistakes, or have we let our guard down? Your thoughts on this? I will start with Joy. Dr. Joy.
Yeah, hi.
Did we make any mistakes here? Now we are facing the pandemic is now, we don't know which wave it is. Is it the second or the third or whatever? But did we learn from this, or have we made some mistakes?
Right. I would say we've had both to contribute. We've had some takeaway lessons, and we've also made 1 or 2 mistakes. The mistake was, I will tell the negative first, so it'll keep others thinking. The mistakes are like, we expected the pandemic to end.
Yes.
We were looking at 21 as a new world altogether, a new era altogether. So new nurses will be inside our colleges. We're going to get them all full. That was definitely a mistake in our thinking. Whereas the opposite was, we're still there. And there are many hospitals that actually shut down their COVID sections and they opened up as a non-COVID hospital. So now for those non-COVID hospitals to recreate their green corridors and to recreate their practices have become very hard. But for some hospitals, like of course the one that I work, we never shut down on COVID. The COVID numbers that we had actually committed to the government, we have been continuing with that. So for us to actually pep up the challenge and to put our step back in came in easy. While I say came in easy, I also realized that, there were a lot of attrition among our nurses because one whole year, because of the lockdown, the e-pass rules, the flight norms, the road norms and all that, girls and boys were not able to reach out to their homes. So when they left to their homes, we didn't have any hold over them. So, they found jobs closer to their homes. Many of them flew to Dubai and Middle East countries because their visas were on hold just before the lockdown. And once the lockdown was just lifted, we had a lot of people just leaving the country, just like that. So we couldn't say no to them because to them, it was really something that they wanted. It's their bread and butter. So we couldn't say that. But then what we've learned from here is that we've made sure that these infection control norms are being practiced on a day-to-day basis, which is a good thing. Infrastructurally, the hospitals are now being built that way, being continued that way, like we wanted more negative pressure rooms. So I think the pandemic gave us enough number of months to create more rooms with negative pressure so that we could admit more people, so that we could care for more families. Today, the wave has brought in families. It's not like one or two. And we are actually mulling over the thought over this weekend. The next few weeks, it's going to be children. So, our directors and all of us have gotten together last, on Saturday. We were thinking we're going to have a pediatric wave hit us. And when pediatric children, when the pediatric age group comes into us as COVID positive, the emotions are going to be very different. The dynamics are going to change completely. So are we really prepared to handle that? We were able to handle adults and we were saying no attenders for adults. But when children get admitted, what are the norms going to be? What are we going to speak? And how are we really prepared to handle? So yes, we've learned a lot of good things from the pandemic, like to keep our stock up, to make sure that we've got our recruitments on time. We recruit excess nurses this time. So this time there's, there is no axe on our shoulder, like only these number of nurses. We're just given the freedom to ask for whatever number of nurses we want. And we're like, running all around the place to recruit, train them, keep a buffer stock, teach them and keep them really prepared for the ongoing pandemic. Of course, the couple of mistakes that I have told you, yes, those are, I think, a little bit, we could have avoided them, but yes, it's okay. It's not too late to bounce back. So many hospitals that have shut down their doors for COVID will be forced to open them up because of the huge numbers that we're actually looking at. So
yeah, but Dr. Joy, you're in a private setup and you're privileged. But what is happening right now in India is the government hospitals are just overwhelmed with, there are no oxygens, there are no patients are being refused treatment because there are no beds.
Yeah. Because they never saw this coming. Everybody thought it
never expected it. Yes,
they never wanted more cylinders in the making. There were notes like you rightly said. They were telling just go ahead and indent for more cylinders. And when we did cylinders, we didn't have oxygen inside them. So yes.
Yeah, right. And probably the reason also is we thought taking the vaccine would really give us 100% protection when and the lifting of the lockdown and going back to the routine has also been a fault on probably a problem that
a lot of mass gathering, a lot of election rallies.
Yes, election has gone in India. Yes, election and mass gathering, religious functions. Yes, thank you, Dr. Joy. Dr. Selva.
Yeah, I'll just speak from the perspective of the
UAE. I want to know UAE is in, is it controlled or is there a wave?
There's slight increase, but not really on the, if you look at the numbers that are at the moment, around 1,500, 600 is what is being diagnosed every day. But some of the good things that UAE did, which is good, is because, as I think I did mention this about a year before, they did a mass testing, and at every emirate crossing, you need to show that you are negative. So their control system was very good from the very beginning. The testing is very important. And now the positive that they have done is vaccination. In every healthcare worker, everybody. And think you must understand, we come from a land where it's quite disciplined in one sense. If you don't follow certain things, at like in the West or anywhere where, you have a choice whether you wear mask or not. But here, if you're found to be not having a mask in a supermarket, you're fined.
Yes.
You're found to be driving a car without a mask, you probably have no one, or you have only a family member. You'll be stopped and you will be fined. So, people are forced to learn that something is asked of them and that has to be done. So I think that's one positive that has happened in this part of the world, that even a small child has to have a mask, when you're taking out. So that kind of, and every place you will find hand sanitizers, whether you go to a supermarket or anywhere, you'll find the hand sanitizers. So the positive that they have done is this vaccination and testing, which has kept them under control. But if you ask me, have they done some mistakes? I don't know, but I always wonder. I'll give you one example. Anybody who's going to other parts of the Gulf country, they're always transiting through UAE, through Dubai. You understand? So I understand they cannot go from, for example, from India to Saudi Arabia. They cannot fly without being quarantined elsewhere. And the elsewhere is always UAE. So that's how it's happening. So, but then, what has been expressed by the country is that we are empowered to internationally be available and have a quality of life. So I have seen that people come here, their economy is now supported by this way. That is, they come and stay here 15 days, they get their tested done. They have to be, of course, vaccinated and tested when they come in, but they can be quarantined here. So their economy is by instead of tourism, it has become like quarantine stay. You understand?
Quarantine tourism.
Yes, tourism. And then, of course, all their flights are being continuously flying, But then when I look at the vaccination as one aspect of it, and also testing is another. So that is something that I want to say that they have done extremely well. But I always fear when other countries around are not letting people directly come. This is one place which is allowing, but they're empowered. One other thing that I'll tell you, as I said earlier, hospitals were, I said in the beginning, as soon as we were hit, it was made as COVID and non-COVID. In between in this process, they have made community hospitals built in every Emirates, which can hold up to 1,500 to more. This Dubai Expo was supposed to happen last time. Now it has got 5,000 to 6,000 beds ready anytime with all the necessary equipment to be able to accommodate any number of sick people who can come in. So that's another preparation that they have ready. You must also understand that they are financially a stable country where they can afford that. And one other thing with regard to nurses, they started in high scale recruitment. Okay, there were a lot of nurses in the country who were registered had a license from another country, but hasn't received their license in this country. But because they have been licensed there, they have taken at a lower level of support to the registered nurses. That's something that they immediately enhanced. The other thing is they started recruiting from other parts of the world to be available for nursing. So if you say, have they learned, have they done mistake? I think the main thing about the positives are about the vaccination and testing and very strict disciplined social distancing.
Yes.
If they are found, there are police who have gone to houses and on a random and found more than 10 people in an evening hour, been fined, and strict discipline has been maintained. So, but then of course I have this fear, how come this country is allowing everybody to come and go through? But I suppose that's where they're maintaining their economy. But then the numbers don't seem to be on the papers much higher because of that.
All right. Thank you very much. A different perspective. Thank you.
Yes, exactly.
Dr. Miriam? Dr. Miriam is there?
Yes, I'm in.
Yeah, Dr. Miriam, I just want to know, in Kenya, has the number increased, or are you stable now? And
in Kenya, we've been experiencing the third wave since February or thereabout, and the numbers have been increasing.
okay.
And we have the vaccine now that many people are getting vaccines, and the ministry has had a priority list of those who are supposed to get that vaccine. The numbers as of yesterday were more than the infection rate as of yesterday was about 14 point something percent, which is still very high. But we are hoping that with increased vaccinations, the numbers should be able to come down. But one thing also that we have noticed is that vaccination per se does not really mean that now you are immune from getting that. Yeah, because we have seen a few people who have been vaccinated, they have contracted the disease, they have developed the severe form, and they have ended up in ICU. And therefore, also, So, I also want to say a little about what we have learned. I think many of us have learned that we cannot put our health to belong to the state and say that the state will take care of us. We have learned that staying healthy is an individual initiative, and whether we are being policed or not, we just have to social distance and put on the mask.
That's true, because I think that's true, Dr. Miriam, because people have to take responsibility for their own health.
Yes. Also, I think we have learned that training of our healthcare workers need to change. Initially, we were not so keen about the skills lab, but this pandemic has taught us that we must put more investment in the skills laboratory for simulation, because the students cannot stay so much in the wards. We have also learned about, we know that pandemics will now come. When we heard about the Spanish flus and others, we thought they were very far away from us. But now we have learned that viruses always mutate, and we really risk having other pandemics in future.
Yes.
But this should now be a lesson for us to learn how to tackle pandemics in future.
Yeah,
thank you.
That's so true. Thank you, Dr. Miriam. Karen, Dr. Karen.
Hi. Currently in Ontario, we are in a provincial order of stay at home. That was announced, secondary announcement was put forth from the provincial government on Friday, extending it to the middle of May. So playgrounds, golf courses, public outdoor spaces have been restricted for access, wanting people to mask. So it's flagged that Ontario is in the third wave. There have been, over the media announcements over the weekend and such, patient movement is happening from larger centers to where there's an available bed. And so some patients are being moved without that information shared with family members. It's in a concerning state for certain. The government has also announced then cohorts of population that can receive immunizations. So initially they had some at-risk category, the older adults. They've now opened it up that teachers and people over 55, etc. Schools themselves have now been put in a provincial order to be fully online learning. The winter break or the March break was extended. The kids are just finishing their spring break this particular week with no returning to classroom session. Everything will be online. And as such, that's impacting even nurses who provide coming to work, of course. You have to have childcare somewhere for your children. And so some of our nurses who have school-age children are certainly in a childcare dilemma. Our first responders are in that. The the government has announced some emergency childcare, but then you must live in that similar geography to qualify for that care. So there are people certainly in some really dire situations just to manage. I agree the masking has been important and emphasized. There are still people who have no intent to mask, the anti-masker. There have been
what is the, I'm sorry to interrupt, but what is the cause of this third wave? I mean, what are they saying?
They're describing it that it's the variant. There's the variants that are coming across. So I don't know specifically which one they're stating, but it's been indicated that it's this third wave coming through now. So certainly some pressures. And just on Friday with my clinical work that I'm doing, I had an update from colleagues in the London area. If an older adult is receiving a long-term care bed offer, they must have a designated person to stay with them, so that delegated caregiver, to ensure that that individual can adhere to the 2-week lockdown or isolation that they require in the long-term care setting upon receiving that bed offer. It just really speaks to that person power abilities. And in terms of fast tracking, I don't know so much about the nursing curriculum itself, but I know the personal support worker program, the PSW, who does that direct care for older adults in community and long-term care settings, they're escalating the program or compressing it to a 6-month, and people are being trained and graduated. There's been some free tuition payments for them to enter into that workforce.
Yeah,
so that's off to everyone in healthcare right now.
Okay, thank you very much. Dr. Joyce?
Yes, hi. I think some of the challenges and some of what we've learned and the challenges that we're still facing, Dr. Karen mentioned those very well in terms of this lax COVID fatigue that citizens are facing, and it's leading to some unhealthy behaviors. Okay. And unfortunately, in the U.S., different states have approached it differently in terms of taking away the mask restrictions and some of the other things. And so we're kind of battling, that in terms of, or it's a challenge for us in terms of still maintaining that social distancing and some of those rules, especially over spring break. As Dr. Karen said, it's been a challenge. Some of the things I think that have been an advantage is that understanding that, with our nurses, as Kathleen mentioned and Karen mentioned, also the fatigue that nurses are feeling related to this constant kind of barrage, and then the different waves in different states in our U.S. Now that are being challenging in terms of that, and the anti-vaxxers movement, which is certainly was present in the U.S. There are a couple hopeful signs. One is that there are more nurses running for Congress and for political offices in the U.S. There's probably not enough, but there's 3 nurses who are in our Congress, our U.S. Congress, and there's nurses also running at the state level, which is where, again, we need to have a voice and have and say something, because it's frequently the national government comes down and has certain restrictions, but when the state, releases, our state governments do things like releasing the restriction on masks and things, then we need to have a strong voice there too. So I think that's very important. We're learning that nurses are also very much feeling the fatigue that a lot of us are, and so as Kathleen said, doing things that will help nurses overcome this moral distress compassion, fatigue that they're experiencing related to this, and being on the front lines between families and patients as far as visitation and other restrictions that have been put on our patients in that setting, because nurses frequently are the ones that have to enforce it or try to help families understand it in a much more complete way so that they'll abide by it. The other thing that I've noticed in my hospital, and I think in other places, has been the much more proactive in terms of having goals of care conversations with patients and advanced care planning with patients within the ethics realm, and being able to veracity in terms of having more honesty related to those conversations. I, again, specialize in oncology, and so having those discussions have always been so important because of the possible outcome of the patient's disease. But then if they also have COVID on top of that cancer diagnosis, it becomes quite important to really understand where patients are at in terms of advanced care planning and goals of care conversation. What is the goal of our care? And I think nurses have a big a responsibility in terms of advocating in those ways. And so I think that's another way, is in terms of educating nurses. And I think nurses have a good, communication classes and things like that, but also educating them on that role of advocating for the patient related to end of life.
Yes, that's so true. That's what we've been, when Miriam was discussing about advocacy, these are the issues that we need to really think about and probably, work on it and in a bigger way.
Yes.
Yeah. Thank you, Dr. Joyce.
Sure.
Kathleen, the clapping has stopped, right, for the healthcare workers now. Nobody wants to clap anymore. So, where are we now, like in terms of appreciation, because the morale is so low among the healthcare workers? And have you learned anything from the previous wave?
I hope we have. I hope we have. And, I think certainly here, to what Dr. Joyce pointed out, there has been frustration and within social media platforms, frankly, anger of healthcare workers, of we have a much greater knowledge today on what are the contributing factors, what puts people at greatest risk for contracting and transmitting COVID. So it becomes very, very frustrating for providers who continue to put their lives on the line in caring for patients. My own area of specialty is palliative care, and I can tell you, two things simultaneously. New York Times had an article out in the last few weeks predicting sort of a massive vaccine surplus in the United States by July. That gets, I don't know how that will now be affected, given that the Johnson & Johnson vaccine here in the United States is on pause. But the difficult conversations that Dr. Newman has very regularly with her patients in palliative care, difficult conversations are the bread and butter of our work. And I can tell you, in a state where we have a tremendous number of people vaccinated, and in a state that I want to say tends to lean a little left, lean more progressive. So there is a lot of adherence to mask wearing. I continue. I have a substantial number of patients who are dying of COVID. So I think, here in the United States where I think we have good reason to be optimistic. We need to also continue to be reminded of our behaviors and the serious risks that in many cases that they pose, and that providers' risk, while have certainly diminished with access to the vaccine, has not gone to zero. And, I think as Dr. Kristen had pointed out, that we not only emerge as nurses from our professional roles, but from our communities. And all of us as professionals come embodied as ourselves, and the communities and our own health issues and challenges that our patients and the community as a whole, perhaps appropriately so, have no awareness of, but there certainly needs to be a sensitivity that as providers, we all bring ourselves and our own stories to the table. And
Yes.
so a degree of sensitivity and an awareness that, not all that is present meets the eye, I think is important generally, but certainly more specifically in these times.
Yeah, thank you very much, Kathleen. Thank you. I think our last discussant, Raya. Raya is there? Yeah. Raya, the reason why I kept you last is because you gave us such an optimistic view of Israel. I mean, I hope that Israel never goes into another wave.
Yeah.
Because, they obviously they have met the challenge head on and are doing well. And of course, the nursing force has also contributed a lot. But do you think there were mistakes in the program, or is there opportunities to learn more?
I'm sure there are always some mistakes that you can learn from. Now we're in the process of learning and investigating the success. We're definitely very, in one hand, we are very optimistic, but on the other hand, we also have some concerns about the different variants and how that's going to affect. Because now, for example, we have like 7 new variant of COVID from India.
Yeah.
So it's new in here. So again, we must be very careful and not, rush and get to fast conclusion, but still continue with some precautions and some, I think, limitations that will still keep the society safe. As I mentioned in the beginning, I do think that the success of the vaccination is definitely, it's a success of the nurses force. And for now, we are more learning what happened during the last year plus, and how, if something will happen again, hopefully not, how we will even improve the fight against this crisis, this pandemic in our society. And definitely something that we didn't talk about is the cost, the financial cost that's gonna have a huge
every country, yeah,
on the country, on health, definitely education and other services. I think that soon we're gonna start talking, realize and get the real picture.
Yeah.
So,
thank you. Thank you, Raya. So I think we've had such a enriching discussion. We covered a lot of topics, and I think we have learned a lot in terms of where we were and where we are now. And there's always scope for improvement, and that we shouldn't let our guard down, because there is this false notion that vaccines are going to give you complete protection. And that is what we should tell the public, because they feel that once they've taken the vaccination, then, they can walk around without a mask. So all these are very important. And of course, like Christian said, about having a coalition for pandemics is very important. And Miriam brought up the issues of health, of advocacy in the curriculum, management in the curriculum, and about sign language. These are all important things that we actually never really thought about before, but this pandemic has caused us to think about it. And it's just wonderful to listen to all of you, and the rich information that you bring to the table is just amazing. And I want to thank all of you for your contribution, and this, especially when we talk about nursing webinars. Nursing webinars are one of the most educative webinars, is what I have noticed in all my 36 or 37, 38 webinars, where everyone comes in informed. And that is really beautiful to see, and the contribution that nurses have to the workforce. So I'd like to thank all of you for taking part in this discussion. And I was wishing that more participants would come in with questions, but they've been silent quite a bit. So I'm not sure what is the reason. Probably they don't want to be as vocal as, the doctors.
Just maybe ask a general question. One area I don't think we touched on was the actual health of, we spoke a little bit about the mental health, but last time I remember we touched on an important issue about nursing professionals who had lost their life in the pandemic. We didn't hear anything. So I'm hoping that the numbers were much less this time around. And directly connected with this, the issue of insurance for nursing professionals. Last year, I remember the government had, of course, given a package of 50 lakhs for doctors. They didn't specify as healthcare professionals. It was for doctors, but even that has been withdrawn now. So maybe just an open suggestion to everyone on the panel. This is something that we can look at in the days to come, looking at an umbrella insurance for nurses, because definitely they are in the highest risk group. And again, like I said, I hope, since it didn't come up, that the numbers of our nursing faculty who have lost their lives directly to COVID are definitely low.
Dr. Derek, I want to say I haven't seen anything about the package for doctors, so I'm not too sure whether it was actually there.
No, I just saw on a different group, I believe about 286 doctors received the package, but the government has withdrawn that. A notification to that has been received. But on the same note, the IMA president, past president, mentioned that there were 786 doctors who lost their life. So it's still
the numbers are there, but I'm not sure about the insurance package.
Yeah, no, the insurance is withdrawn officially. And that same letter which withdrew it claims 286 doctors received the insurance package. So I think going ahead, maybe we can use this, or maybe this could be included in the white paper of the need for insurance for nursing professionals as well, not just doctors. That was my point.
So is that in reference only to India? Is that what you are just saying?
Yes, that was only for India, and it specified doctors. Nobody else. So a lot of backlash was there, where people said that it should include all healthcare professionals, but didn't really work out. And even for doctors, that has been withdrawn as on date. So
one of the things we heard last time, I didn't hear so much this time, was about the nurses. I think the English, we didn't have the lady, the nurse from UK. They didn't speak about it, the impact it had. I think at the last webinar, if you remember, on the nursing. I think we lost. What is the situation now? Can anyone here, at least from United States, I can see it a lot more um, positive there. Do we have many, nurses lost lives and so forth? Probably from Joyce. Any idea?
Myself. Okay,
Yes.
there I am. I think, yeah, we talked last, when we did our webinar
Yes.
last August about several hundred that have been reported.
Yes.
And I know the number is, for healthcare providers, is about 1,500 in the US, at least. Now, those, probably at least half of those are nurses, but that was the most recent statistics I read. Certainly the number, I think, has come down, but we also know that the nursing, we need newer nurses coming on the field all the time, as we do in all countries, because right now the average age of nurses is getting older, so they're at higher risk themselves for COVID, and they're also then going to be retiring or leaving the profession. So we need to make sure we replace them.
Yeah.
But yeah, I don't know if Kathleen maybe has a better figure than I have for the US.
I unfortunately I don't. I think one of the challenges that I think Dr. Joyce, we've talked about, is just there was a real lack of a national repository for good information about deaths. I think the United States, just by virtue of the healthcare structure, we have some degree of government run healthcare, we have city run healthcare, and we have a tremendous amount of privately run organizations. So I do think collation of data becomes more challenging under those circumstances.
Thank you. What about Canada, Karen? Do you have an idea?
I don't have any data that I could speak to. I'm hopeful that perhaps Kristen and I can reach with each other and circulate that back afterwards. But right now I can't speak to that. I don't have any information.
All right.
Maybe Dr. Selva has any information, UAE?
UAE in general, the total deaths have what has been shown is less, and the numbers are very low. If I've only seen a couple of times about a couple of nurses, but then they always had some kind of a pre-morbid, conditioned, which has related. But generally, the death rate has been low and not common among the healthcare workers that has been displayed. But another thing I wanted to say is that every 2 weeks, if you are being exposed to a COVID patient, you have to come with a COVID test negative for you to be working.
Oh, okay.
Right? Yeah. So if you are quarantined and you're sent home, you have to come back with 2 tests that you're negative. So, that kind of precaution takes well in terms of exposing yourself as well. Even students, for that matter. All the students, and the good thing is that everybody is insured, even students are insured. So for all the care. So I think a lot depends on the economy of the country, a lot depends on the policies that are there available, and that reduces the stress as well as for the healthcare worker. So that is something that is commendable for a country like small, but the way they have approached it is really well. The testing and the vaccination that has been mandated. If one of our students, for example, has been exposed because a family member has become positive, she can come to the university and to the clinical area only if 2 tests are negative. So you can imagine the healthcare work availability is more because of that. As I said, they've recruited quite a lot in the process as well. So.
Okay, that's really good. Yeah.
In fact, I don't know about Joy. You could probably. I just spoke yesterday to Dr. Annie Kalamati, who's the registrar. She couldn't make it. She was to be with us, but she's dealing with a big crisis in her state with the COVID. And one of the things she was was telling me that she's being asked to bring in as many students because they are unable to cope with the crisis. As the registrar of the council, the government and everyone's asking, and some of the students' parents are not happy about it. And what's your thoughts about that with the use of students? Again, that was something that we did discuss, where we bring in students. I mean, students are being brought in to help with the outbreak that we're having at the moment, particularly in India. So she did that's the reason she's not able to attend.
I think Dr. Selva has something to say. Dr. Selva.
Yeah, Dr. Selva, please.
Yeah, I just wanted to say that even at the last year, the final year students were called in by UAE to be working in non-COVID areas, so that the COVID, the other registered nurses can be deployed to work in the COVID areas. So even now the students are called in, but they are in the non-COVID areas, you understand. So it kind of takes away the pressure of the other nurses to be working in these areas so that they can be deployed. The students are called in, but not directly in the COVID areas, but all the nurses, including the students, have gone through rigid training program of how to don, how to doff, all protective measures. Every patient is in a way considered to be positive in some way, that's the way they're looking at it. So students are called in. I just want to answer that.
What about Dr. Miriam? What about Kenya? Any numbers about the number of nurses?
Yeah, thank you. Yeah, thank you. The figures I'll give for the 2 weeks ago, we had 75 nurses who had succumbed to COVID-19. I know that in the last 2 weeks, we've lost a few nurses. So that could be around 80. We've not reached 100 yet. But the infection rate has been very high among the nurses. And we've had so many nurses in quarantine. Okay. And this has affected also the work output. And even for students, we have had so many students getting COVID-19. But what we have done also is that the students who are going to the clinic have been provided with some PPEs, and they have also been educated on how to don, how to doff. But it's like almost every patient, about 1 in 10 patients we have are COVID positive. Some of them have not been tested. So we treat every patient as COVID positive. But we also felt that, remember the last time when there was the lockdown, the students all went home. But this time, what the government has done with the lockdown, all tertiary institutions have been closed, but the medical training colleges have been left open, because this is one of the ways that students can learn how to take care of patients in pandemics. Thank you.
Thank you, Dr. Miriam. And I think probably Raya can contribute from Israel. Any nurses who have been affected? Raya? Have we lost her?
I just saw her there. It would be nice to know what's the situation in Israel.
I think she's not there.
Mm-hmm.
Okay, right. I think I'll hand it over to Dr. Russell. Dr. Russell, you can...
Thank you, Mary. Thank you very much. Derek, is there anything you want to add or bring from... Is there anything in the chat?
No, I'll just read out a couple of comments. Joy wanted to say something. Yeah, we'll jump. Go ahead. Please go ahead.
So we also do have a requirement in terms of our students having to pitch in and help us. So like Dr. Selva Titus had just mentioned, we do place them in the non-COVID areas. Right now in Chennai, it's exam time, so they're doing their online tests and stuff like that. So beyond that, we have requested the principals of colleges of nursing, the deans of educational institutions, to really support, and GIFT will be completely taken care of. And if there's something wrong, that the hospital will completely bear their expenses, their food, their accommodation, their place of stay, their communication with their loved ones, and all of that. We've reassured them that they will not be placed in the COVID areas at all till they graduate and get their licenses. So until then, we've been trying to place them in the non-COVID floors like OPDs and, the smaller sections where their help can really be utilized and they will still feel very important to the healthcare. And the nurses who have been with us for the past 1 year during the pandemic in various areas, we've been doing a very slow but steady rotation so that the COVID floors get even the OT nurses to help. Even the OT nurses are given a chance to help there. The cath lab nurses are, going in and coming out, just to give a brief period of relaxation and relief for the regular COVID nurse. So yes, we do take our students there.
Thank you.
Is there resistance? Do you have difficulty getting students to come in? Because Dr. Annie was saying that some parents are not happy.
A lot of difficulty.
Resistance, right? Okay.
Yes. Yeah.
Right.
Lots of resistance. Yes.
Mm-hmm.
Dr. Russell, can I add on?
Yes, please.
Here, students are asked to take an undertaking with the parents' signatures that as a healthcare professional, that it is important that they are participating in the care. And with that consensus, they are. And I think they are made to feel that sense of being available. That is something that has been inculcated into them. So they do take an undertaking, stating that, this is a risk, there can be, not posted in the COVID area, but non-COVID, but they can be. But then they are taking all precaution that if there is any sign that they would be cared for. And parents are also signing that. That is something that we have done with every student when they come. That's been done.
Very good, very good.
And just wanted to add on one point. I think we touched about, but we didn't say, in the curriculum reformation that has happened is focusing mostly on being preparedness for, facing any disaster. I think last time we spoke so much about it, but this time it has come in that they are including courses which is got to face about how to face any disaster. And one of the things that is in very clearly emphasized, not like a general subject, but is separately brought about. They also are bringing in critical care nursing as one of the programs in the undergrad program. It may not be at an overly, specialized, but at least, and as an undergrad that is being involved. The other thing is information technology. How to use this in times of need like this. So, and that is given, as I said, this whole country is looking at the curriculum reformation. In one of the competency framework domain is on information technology, separately put up apart from communication and collaboration, so that the focus is on artificial intelligence and how to use this, because world over now, so that, we enhance that capacity of students and nurses on this field that can be helpful to them in the growth of learning. So as Mariam and Kristen put up, how to empower the nurses in terms of education. This is something that I see it coming through very beautifully. And just not for nursing alone, but the whole country is spending a lot of money on information technology knowledge that has been emphasized. And it has been put as a separate domain, which the nurse has to be empowered in that. So that point was not added. So I thought I will just add on that as well in this discussion.
Thank you. I think you're right. Digital technology, all this is going to become an important competency that even at undergraduate level needs to be brought in. That's what we are seeing now. Yes, that certainly is important. Derek did say that he was going to read out something, Derek.
Yeah, there were just a couple of comments, of course, on use of digital technology. And Dr. Shiba from UAE again confirmed that it's completely voluntary, the involvement of student nurses. And again, a lot of people appreciated that idea. I know it's a couple of institutions are employing that, where you have the students working in non-COVID areas, and that frees up some of your more trained staff to provide cover, because you need a greater number of nurses and more rotation. And of course, this time I think, like Dr. Mary said, our panelists and presenters were so well prepared that they have not left any doubts. In fact, there's just appreciation in the chat box. So really, it's a wonderful learning experience, and great to see that there's so much of positivity around. And despite the not so good news and so many waves coming in, I think we're getting more and more prepared. Let's hope the medication, the vaccination, and the good news continues to rise. And I'm sure the better training, the better preparedness of the entire nursing faculty will act as a huge force multiplier to enable us to face this pandemic even better in the future.
All right. Thank you very much, Derek. And it's a great pleasure now for me to come to bring this, to thank all these distinguished panelists that we have from all the regions of the world. As you could see, we've all contributed from the various parts of the world to a very, very positive and successful conference that took place. Thank Dr. Mary and Dr. Derek for their contributions here, and also to Professor Des Kyle, who does the executive summary of what's happened from Melbourne, from RMIT University. So we also have with us Dr. Deborah from Brazil. Unfortunately, she couldn't, due to the language, we were unable to bring in one of the panelists from Brazil or from Latin America. We tried, and hopefully the next time we will have South America or Latin America also giving their views here. So I want to thank, we've had a number of participants from all over the world. Again, as we usually have, we have Dr. Tara from Iraq, and
Kurdish
Republic of Iraq, and
I think the whole team is there, Dr. Russell. It's
yes,
there's a good number from there.
Welcome to all of you from our Hawla Medical University in Kurdish region of Iraq. So with this, I want to thank you, and we'll continue. What we're trying to do is to continue, and we're beginning to see for ourselves. We thought this would be sort of, we ran, this is the 39th. We thought this was coming to, everything would be coming to an end. And yes, and we'll be looking at other aspects of, rehab and coming back, and as someone said, cost and the other rebuilding and so forth. But unfortunately, we are still now with dealing with the continued mutations and so forth. And so we'll probably have some more, we'll be continuing our webinar program with some more areas, particularly looking at the ongoing third wave and so forth, and its implication. What we need to think, even when I look at what's happened between, and all of you could add, this is the third of the nursing webinars, and we can see slight difference. We are beginning to see different areas of importance and so forth. That's what I sort of looked at, and we're learning from all this. So once again, I want to thank all of you, and we'll continue in solidarity. Kristen brought out the importance of 13, that is where Universal Declaration, Article 13, which looks at cooperation and solidarity and cooperation. And indeed, this white paper, what you published, the proceedings, are contributions which stand out, validating the very important aspect that we bring in this webinar conferences from all parts of the world, the solidarity and cooperation. So I think in 2 weeks or so, we'll be meeting again. So till then, thank you all very much, and stay well and stay safe till we all meet again. Okay. Thank you very much. And
Thank you.
bye-bye to all of you. Bye-bye to all
Thank
of
you
you.
and
Bye-bye.
Bye-bye.
Thank you. Bye-bye.
Bye-bye.
Bye-bye.